True or false? Inhaled anesthetics have slightly different pharmacokinetics to other drugs, but they all have the same solubilities in blood and body fat. 0.5 marks. False. Inhaled anesthetics are small, lipid-soluble molecules that rapidly cross the alveolar membranes, and they differ between their relative solubilities in blood and body fat. Speed of induction and recovery differences explain the mode of action of local anesthetics, such as lidocaine. 3 marks. Bupivacaine, lidocaine, prilocaine, ropivacaine, cocaine, tetracaine. Unionized anesthetics penetrate the nerve sheath. Once they are inside the axon, they are ionized. The ionized drug then enters the Na+ channels in the neuron and binds to the inside of the channel. It blocks the channel, preventing entry of Na+. This plugging of the channel halts depolarization, thereby stopping action potential propagation. Some adverse effects of IV anesthetics are dose-related and common to all except ketamine. Summarize what these adverse effects can include. 3 marks. Cardiovascular depression, such as symptoms of hypotension and hypovolemia, lower blood pressure, respiratory depression, laryngeal reflex depression. Passive and active regurgitation. May also worsen pre-existing cardiovascular and respiratory disease. Ketamine. Increase blood pressure and heart rate. Explain the mode of action of propofol as an anesthetic. 3 marks. It is a very rapidly acting general anesthetic. It, with midazolam, benzodiazepine, and thiopentalbarbiturate, acts predominantly by binding to GABA receptors, GABA agonists. They increase the sensitivity of the GABA receptor to GABA, thereby enhancing inhibitory neurotransmission and depressing nervous system activity. Propofol, itself, may block voltage-gated Na+ or Ca2+ channels, which may inhibit neurotransmitter release at excitatory synapses. Propofol may act as a cannabinoid receptor agonist. Ketamine is an antagonist that predominantly inhibits the excitatory action of NMDA receptors, inhibit excitatory neurotransmission. It may block voltage-gated Na+ or Ca2+ channels. It may activate opioid receptors in the CNS. True or false? Nitrous oxide should be avoided in pregnancy. False. Low potency and low adverse effects. 0. 5 marks. Only one of the general anesthetics, administered intravenously, has analgesic properties. Name the general anesthetic that has analgesic properties and include what receptors it binds to and the type of binding, i.e. agonist, inverse agonist, antagonist, etc. 4 marks. Ketamine is the only agent that has analgesic properties. It is an antagonist at NMDA receptor. Inhibit excitatory neurotransmission. Isoflurane is one of the most commonly used inhaled anesthetics. Explain why it should be avoided in patients with coronary disease. 3 marks. It should be avoided due to potential transient compensatory tachycardia and hypertension. Sevoflurane is preferred. This transient compensatory response can exacerbate cardiac ischemia in patients with coronary artery disease. Hypotension and coronary vasodilation are common adverse effects. Local anesthetics, such as ropivacaine, can be cardiotoxic and can cause myocardial depression as an adverse effect. Which local anesthetic has the most cardiotoxic effects? 1 mark. Bupivacaine, ropivacaine, lidocaine at usual doses. Except cocaine-classed ester. The pre-admission clinic nurse has contacted you because they are assessing a patient prior to surgery and has noted that the patient has a documented allergy to tetracaine. The nurse is asking if it will be safe for the patient to receive lidocaine during their upcoming surgery. Consider the risk of allergy and explain your response, whether safe or not, to the nurse. 2 marks. It is safe. Allergic reactions are rare but more common with the esters than the amides. There is no cross-reactivity between the two groups. Explain why a vasoconstrictor, such as epinephrine, might be added to a local anesthetic such as bupivacaine. Are there any risks from doing this? 2 marks. Most local anesthetics cause vasodilation, except cocaine. It is added to induce vasoconstriction, slowing the rate of absorption, and prolong the duration of action of the local anesthetic. Adverse effects include anxiety, pallor, hypertension, sweating, or arrhythmias. These effects commonly rectify on stopping the drug. Why is propofol particularly useful for anesthesia in day surgery procedures? 3 marks. Useful for day surgery due to its very rapid recovery and antiemetic effects. It has a rapid action tilde 30 seconds and a short half-life of 2-4 minutes. It causes less post-operative nausea and vomiting than some of the other agents. What adverse effects can occur if propofol is used at a high dose for a prolonged period? When given as a high dose, prolonged 48 hours continuous infusion, propofol may cause a syndrome of adverse effects including arrhythmias, heart failure, renal failure, rhabdomyolysis, fatty liver, and death. 3 marks. This question has 2 parts. 1. List the 4 essential components for anesthesia. 2. Do all anesthetic drugs meet these 4 anesthesia requirements? Explain your response. Include in your answer how this might be managed. 4 marks. 1. Analgesia, blocking the ability to feel pain, relaxation of muscle immobility, unconsciousness, amnesia. 2. Some anesthetic drugs may not block pain or relax muscles, used in conjunction with analgesics, opioids, and neuromuscular blocking drugs, muscle relaxants. What drug class can be used as a general anesthetic, anxiolytic, or as an antiepileptic? 1 marks. Midazolam, which is classed in benzodiazepine. In the treatment of migraine, why might paracetamol be administered in combination with metoclopramide? 1 mark. Non-opioid analgesics, paracetamol, NSAIDs, aspirin, are the first-line treatment for mild to moderate migraine symptoms. They are often combined with an prokinetic antiemetic to improve drug absorption. How does paracetamol exert its antipyretic effects to reduce fever? 1 mark. Its antipyretic effects may be due to reduced production of prostaglandins in the hypothalamus. Analgesic, inhibition of central prostaglandin synthesis and modulation of serotonergic pathways, may also interact with endogenous opioid and cannabinoid systems and act as a weak COX-1 and COX-2 inhibitor in peripheral tissues. How many pathways is paracetamol metabolized by? Explain how this can lead to hepatotoxicity and overdose. 5 marks. Paracetamol is metabolized by 3 different pathways. 1 metabolic path in the liver produces a highly reactive metabolite N-acetyl P-benzoquinone imine, NAPQI, that is toxic to liver cells. In normal doses, intracellular hepatic glutathione binds to NAPQI, and it is eliminated in the urine. In higher doses of paracetamol and the increased NAPQI levels deplete the glutathione stores, resulting in damage to hepatocytes. Which one of the following opioids is a partial agonist at the mu-opioid receptor? Pethidine, tapentadol, buprenorphine, tramadol. 1 marks. C. Buprenorphine. What drug is used to reverse the effects of paracetamol overdose, and how does it achieve this? 2 marks. N-acetylcysteine, NAC, is used in overdose when there is a risk of hepatic injury. NAC is a sulfhydryl group donor and detoxifies NAPQI by repleting glutathione stores and conjugating directly with NAPQI, serving as a substitute for glutathione. Briefly explain why tramadol can cause nausea. 1 mark. Opioids stimulate the chemoreceptor trigger zone in the medulla. Giving an antiemetic may be beneficial. A patient should be prescribed supplied with a stimulant laxative, with a stool softener when taking oxycodone. Briefly explain why this is. 1 mark. For constipation, as opioids increase GI tone and reduce GI motility. Regular use of a stimulant laxative and stool softener is essential when patients start chronic opioid treatment. Patients prescribed opioids might have their degree of sedation monitored as an early warning sign of what adverse effect. Explain why sedation is used to monitor for this rather than respiratory rate. 2 marks. Dose-related respiratory depression. The respiratory rate is not a reliable indicator of respiratory depression, so it is judged by the degree of sedation a patient is experiencing as this precedes respiratory depression. This question has 4 parts. What receptors does naloxone act at? What activity does naloxone have at that receptor, i.e. agonist, partial agonist, antagonist, inverse agonist, etc.? What indication is naloxone used to treat? What is the duration of action of naloxone? What is the significance of naloxone's half-life? 6 marks. Opioid receptor antagonist for opioid overdose. intoxication, and opioid sedation less than 1 hour of half-life, so may require repeated doses or an infusion. Naltrexone opioid receptor antagonists, reversible, as an adjunct in maintenance of abstinence from opioids after opioid detoxification. 2472 hours duration. Which two analgesic drug classes are used in the treatment of neuropathic pain? Name one drug from each class that is indicated for neuropathic pain, based on evidence of efficacy. 3 marks. For the acute treatment of neuropathic pain, provided an adequate dose, can be reached that provides analgesia without excessive side effects. Pure opioid agonists. Morphine, oxycodone, tramadol's monoamine uptake inhibiting properties may contribute to its effectiveness. While the gabapentinoids anticonvulsants, pregabalin and gabapentin, are commonly used for neuropathic pain, carbamazepine is used less often. What painful condition might carbamazepine be indicated to treat? 1 mark. Carbamazepine, some other antiepileptic agents as well, that block sodium channels, can be effective in treating trigeminal neuralgia, but lack evidence against other neuropathic pain. Compare and contrast eptinezumab and erenumab in the treatment of migraine, with a particular focus on their mode of action. CGRP antagonists, parenteral, eptinezumab, erenumab, fremanezumab, galcanezumab, eptinezumab, with fremanezumab and glacazumab, inhibit CGRP vasodilation by binding to CGRP and neutralizing it, while erenumab binds to the CGRP receptors blocking them. 3 marks. Name the calcitonin gene-related peptide, CGRP, antagonist that can be administered orally. What is unique about this agent compared to other drugs available for migraine? 1 marks. Triptans, aletriptan, naratriptan, rizatriptan, sumatriptan, zolmitriptan. Triptans should be trialed the next time when a patient with mild to moderate migraine symptoms does not respond to a non-opioid analgesic. For severe migraine symptoms, it may be appropriate to initiate treatment with a triptan. Explain the mechanism of action of fentanyl in pain management. 3 marks. Opioid analgesics. Pure opioid agonist, with morphine, hydromorphone, oxycodone, pethidine, tapentadol, tramadol. Asterisk partial agonist buprenorphine bind to the mu opioid receptors analgesic effects of opioids, and for some major adverse effects, respiratory depression, sedation, constipation. Delta opioid receptor analgesia, but also can be proconvulsant. Kappa opioid receptors analgesia at the spinal level and may elicit sedation, dysphoria, and hallucinations. ORL1 receptor, anti-opioid effect at supraspinal, analgesia at spinal, immobility and impairment of opioid receptors, delta opioid receptor, kappa opioid receptor. ORL1 receptors are inhibitory G protein-coupled receptors, G/G0. The drug binds to these receptors results in inhibition of adenylyl cyclase and decreased CAMP, which has effects of promote the opening of potassium channels, increased potassium conductance out of the cell, hyperpolarize membrane, decrease neuronal excitability, inhibit the opening of voltage-gated calcium channels, reduce calcium entry into presynaptic terminal, inhibit neurotransmitter, acetylcholine, norepinephrine, glutamate, substance P, calcitonin gene-related peptide release. These inhibitions lead to decreased activation of numerous neuronal pathways. Asterisk morphine binds the brainstem opiate receptors, which activates the brainstem descending serotonergic pathway to spinal cord to inhibit the release of neurotransmitters responsible for pain perception.